Hi, I'm Dr. Arvind Kumar. I'm an orthopedic consultant with special interest in spinal surgery. I actually graduated from Madras Medical College and I decided to do orthopedics very early on. So I went to the UK, which even now is probably one of the strongholds of orthopedic training. And I entered the Welsh orthopedic training in Cardiff and completed that. Then I got interested in spinal surgery at a very early stage and pursued that after my orthopedic training was complete, after my FRCS. So I did my spinal training from Cardiff, and then I went to Perth in Western Australia for a year, and back to Nottingham in UK for a year to continue my spine fellowship. And so I got trained in virtually every aspect of spinal surgery, from your simple fracture fixations to decompressions and a wide variety of injection therapies to instrumentation, your TLIFs, your ACDFs, your posterior cervical laminectomies, scoliosis correction, complex spinal trauma, corpectomies. And I came to Singapore 2014, and I've been lucky enough to practice all these complex spinal operations. And I also fine-tune my minimally invasive spinal skills. So I could say that there is probably no region of the spine that I cannot approach minimally invasive. Now, minimally invasive is open to interpretation, but there's your normal incision that you can do in a minimally invasive fashion. There's tubular sort of operations. There's endoscopy. And so I can honestly say that virtually I can use every one of these tools to deliver whatever spinal treatment is required. So the first step is, obviously, there's very few instances in spine where a surgery is required on a very urgent basis. And in most instances, there's always a chance and an opportunity to try non-operative managements, including appropriate medication. And when the patient has failed such non-operative medication, he continues to have significant back pain or nerve pain or both, which is impacting on the lifestyle and work, then surgery is indicated. And nowadays, minimally invasive instrumentation is so advanced that virtually any surgical treatment can be delivered in a minimally invasive fashion. I suppose the first step is, to answer your question, is when the patient has decided that other treatments haven't worked and they enter the doctor's office to tell him that would be quite literally the first step towards a minimally invasive spinal operation. Absolutely, that is a great question. Spinal navigation technology has been around for more than a decade now, and we've been using this on a very regular basis in Singapore. And I'm completely sold on it. There's a few things to it. One is you touched on fluoroscopy. I belong to the old school. I trained in the old school fluoroscopy for minimally invasive spine, and wearing a heavy lead gown, the lead goggles, and so on, the collars and everything. It's not great fun, especially when you're doing a very complex spinal procedure. You could be stood there for 7-8 hours wearing these lead gowns and sweating like anything. And it's a very, very uncomfortable operation. And there is always a problem with radiation damage. And you do hear about doctors who developed thyroid cancers, had radiation keratitis, and so on. You do hear about it, and it's quite worrying. So the onset of spinal navigation has certainly made life a lot easier for us from just the fluoroscopy and comfort point of view. But also the accuracy. There's time and again, so many papers, even I've published a paper on comparing the accuracy of screws that are minimally invasive pedicle screws that are placed using navigation and under fluoroscopy. And there is a measurable improvement in accuracy with navigation. And when you add in the extra cost of navigation equipment, it is still cost effective. I think the number of operations we do in Singapore, minimally invasive, it really more than makes up for the extra cost. So yes, both in terms of radiation damage, in terms of comfort, and in terms of accuracy, the spinal navigation definitely has a lot going for it. Thoracic discs are very common among a subset of the Singaporean population and can be particularly bad in obese people, diabetics, and sometimes they're diagnosed very late and they can present with significant thoracic myelopathy. And some of them can be really difficult challenges, especially when you have multiple level thoracic discs. Nevertheless, we deal with them when there is a spinal cord compression from these. We can deal with them. Because of where they are, it is not always feasible to do them from the back. So when you approach them from the posterior direction, you'll have to do a very lateral approach where you come in from the spine from very, very laterally instead of down the middle. And then you can approach it from both sides. We can use navigated drills and we can burr it from the anterior side and thin out the disc. And then once it's thin enough, we can go between the calcified layer and the spinal cord, and then we can push down the thoracic disc. So that one is easily done. Anybody can do it. And obviously in those instances, we need to instrument the spine as well, because there is some instance of recurrence if you don't instrument the spine. The other more elegant way of doing it, which is what I prefer, is if there's one or two levels, you can do through lateral access. There's a number of companies that give you these lateral access retractors. You can do it minimally invasive. You can slip in between the ribs, or you can take out one rib and then you can slip in. You can sweep forward the pleura and the peritoneum, and you can land right on the lateral aspect of the vertebral body, and you use X-ray to guide you down to the disc. You can take down or trim down the rib head a little bit. You can get down again. You approach from anterior aspect and make your way slowly towards the calcified fragment. And again, once you thinned it down enough, you can tamp it down. And if you're doing one or two levels with this technique, you don't actually need to instrument the spine. But if you've taken down a lot of the bone, then you may have to instrument it, but that can be done in a minimally invasive fashion. So currently, that is my preferable option when it comes to thoracic disc herniation management. It can be applied to all patients. That is a short answer. But one should keep in mind the current robotic technology, while we're already into the third generation now, it is still only catering to the placement of pedicle screws. So the answer to your question is it can be used to place pedicle screws in any patient. So your usual T-lifts, your fracture fixations, your scoliosis, adult scoliosis, adolescent scoliosis, all of them, it does improve the quality of your life quite tremendously. So that's what I would say. But I look forward to a time when the robotic technology can be used for a wider variety of spinal procedures, including pedicle screw placement. So and I think I can soon see a time when robotic assistance or navigation can be used to access very intricate parts of the spine. For example, thoracic discs even, where marrying the CT scan with the intraoperative pictures and the disc and the robo can then take you very accurately down to the disc level and also help you burr it down very accurately with a much lower risk of spinal cord damage. So I think that would be a significant advance, especially if it starts to allow you to place your interbody cages. I would see that as a significant advance. But as it stands now, it does make life a lot easier. I suppose it's a step above navigation when it comes to accuracy and ease of surgery. But at the moment, it is still a one-trick pony. Even though the modern systems are able to combine navigation with the actual guidance, so they are better, but we need them to do more. That's a great question, and very interestingly, spinal surgery, for some reason, the rates of deep venous thrombosis are far lower than in fields such as lower limb surgery, for example, hip or knee arthroplasty or pelvic surgery, those rates are far higher. And I myself did a study in Cardiff, which highlighted, we looked at anterior spinal surgery, which theoretically is comparable to pelvic surgery, and I was able to show that the DVT rates were far lower for ALIF surgery as compared to pelvic surgery. It's not exactly clear why this is the case, but it is so. Now, the other side, the flip side of the coin is the usual chemo prophylaxis, for example, your Clexanes and the newer Roxabans that we use. The problem, though, the worry, and certainly it's a well-justified concern in spinal surgery, is the risk of post-operative hematoma, which can cause and does cause devastating post-operative neurological deficits, which don't always recover even with urgent surgery. So our concern is more skewed towards how do you protect the patient from the complications of a hematoma. And given that the literature evidence is the DVT rates are lower in certainly in spine surgery, we somehow tend not to routinely place people on chemo prophylaxis. But what we do is there is always an intraoperative cuff pump, which I continue post-operative till the patient is completely mobile. There is early mobilization of the patient. There's no question of bed rest after spinal surgery. We mobilize them the next day, and some of them mobilize the same day. There is plenty of good hydration and exercises going on. There's even when the patient is in bed, they're taught exercises that they have to do in bed apart from the time that they're mobilizing. So it's a very, very active management. Giving chemicals is very easy, but the risk-benefit ratio is not really in favor for those things in spinal surgery. Of course, there are different subset of patients who are very high risk, who have multiple PEs, DVTs, and they have to be managed together with your hematology consultant, where you will have to go through the usual practice of covering them intraoperatively and post-operatively, but they'll have to be watched very, very carefully for the risk of post-operative bleeding and complications. So the short answer is the rates of DVT seem to be lower in spine surgery, and we use mechanical means far more commonly than chemoprophylaxis. Yeah, that's very true. It also depends on what sort of spinal trauma it is. For example, if they have a spinal cord damage, for example, like a central cord syndrome, then it becomes very difficult to manage them, because it affects the whole body. The blood pressure is very labile. They are very prone to chest infections, and the presence of comorbidities really complicates the situation. And nowadays, especially for central cord syndrome, the understanding it's moved away from do not touch to now we recommend early surgery for them. And there's good evidence, especially with the advances that our anesthetic colleagues have made. They've made surgery so safe for this group of patients that we recommend very early decompression of the spine in a central cord syndrome. Now, the other common issues we see is fracture dislocations. And, the oldest patient I've ever operated with a spinal fracture dislocation was a 107-year-old. And after due discussion, we did an operation on him, and he did very well, and I still remember taking a photograph with all his 27 grandchildren, and I think it was about 40 plus great grandchildren, and he was very happy. So you have to, it's not the age is just a number. You got to, of course, look at the comorbidities. And nowadays it is very clear that there is no role for prolonged bed rest for the management of spinal injuries, or indeed for most orthopedic injuries. And with the levels of safety that anesthesia has reached, we are able to get these people back on the feet and back home much in a much better and safer way than we were ever able to in the past. The advances in instrumentation also play a part. We have minimally invasive instrumentation in lumbar spine. In cervical spine, we have very reliable instrumentation which allow us to do these things as well. The difficulties come when there is significant spinal cord damage, or when there's significant pre-existing deformity, like in ankylosing spondylitis, and those become tricky operations, and they have to be very carefully discussed with the patient. But by and large, early surgery, early decompression, early stabilization, early mobilization, and early rehab definitely are more likely to give you a positive outcome, regardless of the age of the patient. and even in the presence of comorbidities. It's interesting. I still remember my medical school yearbook. I said I would be a time traveler. Yeah. Well, I think I would have been on some technology front. I would have been somebody who's inventing things. Even in orthopedics, especially spine surgery, is a very tech-heavy field, and I love playing with these things and just being in the application forefront. So almost certainly I would have been on the tech side. I would have been inventing things and getting patents for this and that. And I think that's probably what I would have been doing. Yes.